Hello, my name is Asha Kilaru, and I work in public health. I am also the director of the Bangalore Birth Network. We are a nonprofit based in Bangalore, India. The title of my talk is Narratives in Care Seeking. And these are narratives from socioeconomically vulnerable women in South India. These stories are taken from women as they seek care for pregnancy, birth, and postpartum through the telling of their experiences in their own words. I share with you a few examples, one long and three short excerpts from different projects involving research with women during the obstetric period. These stories convey how their lives are fraught with various types of risks to their survival and how poorly the health system understands these risks. Healthcare in itself becomes catastrophic. So the stories are from Dalit women in urban slums of Bangalore, from tribal women, women in villages in South Karnataka, and women from the postpartum wards of a government tertiary maternal and child health hospital. Why is this important? And why are we talking about listening to women and narratives of women at this conference for normal birth? The broad aim of all of us here is to promote woman-centered, evidence-based, compassionate care that strives for immediate and long-term well-being. At the core of this is normal birth, wherever possible and desired, and the midwifery model of care, which places women's well-being at its center. It's imperative that we expand the transformation that's unfolding to include all women, especially the most vulnerable, who receive the lowest standard of care. The vast majority of those who are poor are buffeted by fear, alienation, lack of continuity and consent, and catastrophic costs in their experiences of care seeking. And to be poor and low caste is a double burden. They face a multitude of risks, sometimes made worse by healthcare. Hospitals, clinics, health services, and providers perpetuate the lack of social power and political marginalization. Therefore, it's essential that we develop a more attuned listening to people's experiences and beliefs in their beliefs of themselves and their health. By understanding the context of people's lives, we create the beginnings of institutional change. So some of the risks that you will hear about in these stories are listed here, and they are physical, financial, and social. There's much literature on the quality of care and on advancing the integration of person-centered care and public and patient involvement in healthcare. Patient participation improves health outcomes. It enhances quality of life, and it drives more appropriate and cost-effective services. These approaches are important not only for the purpose of improving quality, but as part of the fundamental right to health. The United Nations issued a legally binding interpretation of the human right to health, that is, the right to the highest attainable standard of health, and put forth that participation is a necessity for overcoming inequalities. The core of building a participatory agenda is listening, and with the objective of empowering people to participate in the content and decisions of their health and healthcare. Narrative medicine is an approach within quality of care which trains providers to listen with empathy and caring. In social science, narrative analysis, similarly, is a powerful approach to understanding people's experiences. In the words of Kathy Reisman, a leading scholar in narrative analysis, people live storied lives. Narratives can take the form of text, spoken language, numbers, physical movement, and spatial constructs. Individuals tell narratives, as do groups, organizations, professions, industries, governments, and nations. And these are a part of larger historical and cultural narratives. When we empathetically listen, we glimpse the content of a person's life. Through this lens, we validate the actions and decisions they take. However, if we assume that people are impoverished, not only economically, but lack the ability to make rational decisions and the ability to understand causation, We justify exertion of control over them. In this narrative, dominant among providers and health systems, the withholding of information and beliefs that the poor are inured to pain and suffering and thus do not need measures to alleviate pain as examples become justified. The first example is from a conversation with a young woman, Bhagya, who's 19 years old at the time of this interview, and her grandmother. And her grandmother is primarily the narrator. They live in a rural area in South Karnataka. Bhagya was married before the age of 18. NFHS4 data from Karnataka showed that 25% of women aged 20 to 24 were married before the age of 18. Since COVID, NGOs report an increase in early marriage because of the shutdown of schools and colleges and employment. Bhagya's family's priority was to find a groom with an affordable dowry. The hope was that the family would treat her well, but her family and her husband and his family actually harassed her for more dowry and abused her. I met Bhagya for the first time a little over a year into her marriage and at the time of her first pregnancy. Her grandmother explains the background. I adopted Bhagya from my daughter. When she was born, her father and her mother tried to commit suicide. I took care of Bhagya. I brought her up and got her married. I bore all the expenses for her marriage. We gave 15,000 rupees for dowry, a gold chain and earrings. I did the best I could for her, but I put her into a terrible situation. She goes on to describe her own sense of futility and helplessness and talks about her not having an education. And she says, my husband died 2 years ago. I studied to the second standard. My right hand is narrower than my left, so I found it difficult to write. And I was interested in studies. What can I do after studying? Our education is work, and my work is caring for cattle and sheep. Bhagya's situation is typical of many women, and her experiences in accessing health services and entitlements reveal the gender and social discrimination overwhelmingly disadvantageous to girls and women experience from birth to death. Bhagya had little social support that could help her abusive home life. Bhagya started labor at night, and she went to a PHC. There, she was told it's false labor. There are no facilities to stay in the PHC, so we went to the nurse's house and we stayed the night. We didn't meet the doctor at the PHC. The next morning, she was told to come back every day for injections. Her grandmother was with her for those visits. Each visit during those 11 days, 5 of them cost 100 rupees, including bus charges and medicine. We purchased medicine on each visit. Each time we were asked to buy different things. Even Horlicks. I had to pawn all my jewelry when we first went into labor. I pawned my earrings for 2,000 rupees. The doctor came at 10 a.m. They put Bhagya on drip. The delivery took some time. They advised us to take Bhagya to another hospital, but the A&M told the doctor that we're very poor and he should try to conduct the delivery there. Finally, Bhagya delivered in the PHC. So here she's referring to the costs that occurred at every hospital that the poor seek care. And this is a common story throughout research that looks into care-seeking behavior. We paid the nurse 150 rupees, the doctor 200, auto charges 50, and auto charges and rupees 50 to clean the bed. In fact, we paid 1,500 rupees altogether. The sister wouldn't take money from us because she knew we're very poor. The Janani Suraksha Yojana scheme is a conditional cash transfer program to help below poverty line women with costs associated with delivery. And in Bhagya's case, it created a tipping point for a suicide attempt. Her in-laws treat her very badly. Bhagya was here with me last week, and now she's gone back to her in-laws. Her mother-in-law would not let her bathe. She was here for her Banantana. At that time, she gave me her gold chain for safekeeping, but her husband asked to bring the gold chain back, abusing her. So when he came back here last week, we gave the chain back to her. When you visit Bhagya's house next time, she said to me, please talk to her and give her the courage to face these problems. She is very innocent. She can't handle all of this by herself. I keep telling her that there are many ways to live life. The world is so big and she has to find a place, but she has to get that courage. A month and a half ago, she tried to hang herself because her husband had beaten her badly. This was because of JSY money. I bore all the expenses for the delivery, but her husband insisted that she give him the JSY money and beat her up and threatened to send her back to my house. Violence is widespread in women's lives and wreaks havoc on their emotional and physical health. Domestic violence is rarely screened by doctors or health workers. NFHS4 reported that 52% of women and 42% of men agree with one or more of the 7 specified reasons for wife beating. This has declined for men since NFHS3, but has remained unchanged for women between rounds 3 and 4. The next excerpt is from a woman who was referred to a hospital in Bangalore from a village, and it was part of a study we did on obstetric referrals. I wanted to deliver at the PHC, but we were referred to Bangalore. After we paid rupees 2,000, the doctor conducted my delivery. Bangalore hospitals are not for poor people, only for the rich. We spent a total of rupees 7,000. We had problems getting the money. She and her baby were discharged without any medical problems. However, the financial burden was catastrophic for them, and she said she'd rather die than incur such debt. She also did not receive any postpartum care. Maternal health programs in India have been primarily focused on antenatal care because of how they're linked to improved outcomes for the infant. Once the baby is born, interest in the woman wanes. NFHS4 data show that 84% of women received an ANC checkup, and only 65% of them received a PNC checkup in the first 2 days after birth, when the majority of maternal morbidity and mortality actually occur. And only 27% of newborns received a postnatal checkup within 2 days of birth. The next story is from a young woman named Shruti, who lost her baby and also incurred a lot of debt. And she is from a tribal population, and they're especially vulnerable and discriminated and affected by the risks of healthcare itself. Shruti was diagnosed with severe anemia in her 7th month of pregnancy. Her child died at birth, and the family incurred an expenditure of 50,000 rupees, which they have to repay on their meager earnings of 150 rupees a day. The next case is of a tragic maternal death, a woman named Basama and her unborn child. She was taken to the hospital in the taluk where she lives, closer to her village, and then from there to a hospital in Mysore because of severe complications. There, the doctor said they should take her to Bangalore, and the family had no money left because they made payments along the way at every stage and for multiple reasons. And they had to remain in Mysore, and she died that same night. We have to pay for everything, her aunt said. The ambulance would have taken us to the hospital in Bangalore, but we would have then had to bring the body back, and that would have been very difficult. We don't know anything about Bangalore. This is a photo of her firstborn being raised now by her father-in-law. One woman said to us, "They don't like our community. They think that we don't know anything. They scold us in English, stupid and idiot. They don't care for us, and they send us back from the hospital. Since we belong to a backward community, they don't care about us at all. If other classes or communities go to them, they take care of them and they do the delivery. People who are uneducated are scolded by doctors and nurses, and even if they're hit, they'll stay quiet." Reproductive health programs are supposed to address women's health needs throughout their life cycle, but in practice, a large portion of women receive meager, low quality, and often harmful and costly care. The National Health Mission is a response to expanding health coverage, and however, it is a tiered system for healthcare access, and it falls hugely short of universal healthcare. So, in conclusion, women from vulnerable communities experience profound risks to their lives and well-being. At this juncture, as we usher in expanded midwifery care, we have an opportunity to make a radical change in the way we care for poor women. We must start with attuning ourselves and our organizations to the risks they face. We need to ask ourselves, what risks do women perceive, and how does this affect their response to healthcare? What are the dynamics and drivers of risk prioritization at the individual and family levels? And what risks should healthcare address? And which ones should healthcare be held accountable for? These are credits of people involved in the research and the data collection. And I'd like to thank the Fernandez Hospital and Foundation, and especially Evita Fernandez. I'd like to thank you, Clan and UNICEF, for the opportunity to be here with all of you and present at the conference. And I've learned so much already. Thank you.